All right. So welcome to Talking Data Equity for Friday, May 1st. And I'm Heather Krause. I'm the founder at We All Count. And Talking Data Equity is what we do on Fridays at noon Toronto time to have an informal conversation about people who are practicing applying data equity ideas and tools to their work with great success, with great challenge, and everything in between. And today I am so excited to be able to have as our special guest Dr. Azadeh Yadollahi. And I had the great privilege to meet Azadeh at an event that was held here locally, a University of Toronto event. And I was blown away by the work that she was doing. She's a bioengineer and she works across several prestigious universities and research centers here in Toronto, including but not exclusively the Toronto Rehab Institute. And she is doing many fantastic projects, but the project she's going to talk about today is some work that she did on collecting information from people experiencing homelessness. And that's all I'm going to say, because I'm going to let Azadeh share her screen and really share her story with you. And after that, after we get some grounding in the work, then we'll open it up to questions and answers. And when you have a question during that time, there's two ways that you can ask your question. You can either put your question publicly in the chat so everybody can see it, or you can put it privately in the chat so only I can see it, and then I'll ask. Or if you would like to raise your hand, you can just use the Zoom raising your hand emoji, and we will do our best to unmute you in the order in which you raised your hand, but that won't be perfect. We'll just do our best. Okay, enough about housekeeping. Over to you, Azadeh.
Hello, Heather and everyone, and I'm so thankful for being here. It was a true privilege to chat with Heather in the meeting that she is referring, and I learned a lot from her. I'm just going to apologize in advance. I mean, my daughter may jump in because she's just leaving the house to go to daycare, but she may jump in. That's what she usually does. And I also have a dog here that she may fall asleep and start snoring. So I have all the interactions that can happen. So thanks again for having me. And as Heather mentioned, I'm so pleased to be here and present the work that I'm doing, and more to hear from you and your thoughts. And this is the work that I'm going to present is more of a journey that I experience, and I'm learning from that. So it's a continuing learning opportunity for me as it goes. And it's about the journey of the research partnership that I started almost a year and a half ago with people with lived experience of homelessness. So I'm a biomedical engineer, and usually what happens is that in our research, it is in general a multidisciplinary research. And when we design any research, we try to make sure that we are having different people at the table, such as researchers, physicians, industry partners, engineers, business developers, and also the design expert. Another question, or the more important question, is who is missing at the table here? And I was quite shocked after many years of doing research when I was in a meeting with one of the patient partners of Dr. Heather Ross, who is a pioneer in patient engagement in the research. And the patient mentioned that when diagnosed, I changed from a person to a patient. Then in a trial, I became a subject. My identity was completely stripped away. Can everyone be an agent in this process? And it was quite eye-opening for me that I've been doing this research for almost about 20 years, and I never thought that if I'm doing any research, I need to have the end user, for example, the patient or their care provider, at the table from the very beginning. And why is that important? So to my understanding, There's so many things that could go wrong if we miss the end user and if we don't include them. Just to summarize, for example, in defining a research question, are we really asking the right question? Does it matter what we define as a research project? How we are collecting data, what tools we are using to collect data. Are they helping or increasing inequity? How are we analyzing the data? Is it going to lead to misleading information by not including the end users? And then when we are going to report our results, for example, to the community or publish it, are we going to add to the stigma that exists? And that is a very common problem when dealing with underserved population in the research. And finally, the solutions that we are proposing, are they really helping? Or because of the lack of interaction with end user, we are actually adding to digital divide? So today I'm going to talk about two of these experiences or two of these challenges that I experienced firsthand in my experience with people experiencing homelessness. Just as a very quick overview, what happens is that when I started working, the reason that I started working in this topic of the the health challenges in the people experiencing homelessness was that actually at the very beginning of COVID. And I had a very close friend who worked with City of Toronto, and she told me that she's doing like administrative work for the City of Toronto. And one day she told me that I'm very scared. I'm like, what's happened? And she said there are some challenges and we have to help with the management of the shelters in Toronto. And I'm assigned to go to the shelter at night in a shelter which is in downtown and mainly with male residents, and then help with the management of the shelter at night. And I said, okay, what does that mean? She said, part of my responsibility is to make sure that the people are breathing at night. And for that, when the people are sleeping, and at that time, it was like a congregate setting, everyone is on the different bed. What I have to do is in the middle of the night, I have to go by each bed, see if they're breathing or not. And if they're not breathing, try to put my hand on their chest and make sure they're breathing or not, they're having any overdose episode. And I don't know how to do that. And I was so shocked that, is it really happening at this day with all these digital technologies everywhere? Why do you have to do that? I mean, if someone comes to me and touch my chest, if I'm breathing or not, I may wake up and just punch them in the face because I'm so scared of someone touching my chest. And then, so this is a really dehumanizing and they're really actually affecting the dignity of the people for both sides. And it could really add to a lot of violence unwanted. Why should we do that? And my work was about all these wearable technologies to monitor sleep. So that's why I was quite shocked. So I started to learn more about the health challenges and the care for the people who live in the shelters. And what I understand or I learned was quite shocking. Unfortunately, the people who are in the shelter, the mortality is about 5 to 10 times higher than the general population. It's very common for them to have multiple chronic disorders. And because they don't have a proper access to the healthcare system, a lot of interaction with the healthcare system is through emergency department visit, which means that when everything went wrong and it's too late. And when you look at these different chronic disorders that the people in the shelter have, a lot of them are common with a sleep problem or a sleep apnea. And a sleep apnea, you may have heard of that. It's a problem that people stop breathing during sleep because the pharyngeal airway collapses, and it significantly increases the risk of heart attack, lung disease, and even mortality. And it has many common causes or comorbidity like diabetes, obesity, smoking, and these are all quite common in people in the shelters. However, there's no study on the prevalence of sleep apnea in this population, not in Canada, not anywhere in the world. And I'm like, I got my research question. That's the best question to ask. Let's look at the prevalence of sleep apnea in the shelter residents, because no one has done that. It is very important, and it probably increases mortality. And at the moment, as I said, no one is looking at the sleep apnea, just whether they're breathing or not at sleep, and that is manual. So seems a very clear research question. And then how can we detect if someone has a sleep apnea? So the clinical way is something called full polysomnography, which means that the patients should come to the sleep lab, for example, in downtown Toronto. They stay overnight in the sleep lab. They have about 20 sensors connected to them, and then that will detect their sleep apnea severity. But then this is not something feasible for the shelter residents. It is so hard to follow up with them, make appointment with them, which may take 3 or 4 months. Many of them don't like to come to the hospital because they don't trust the system, or they're even scared of losing their bed in the shelter if they spend one night somewhere else. So the next solution is a portable device for diagnosing sleep apnea, something like this one. And we actually try to find the best device in the market, in a sense that it has Health Canada approval. It is supposed to be able to do everything, with the people connecting it to themselves. And it has a very nice feature that it can record the brain signals to monitor a sleep structure easily over the forehead, compared to these other methods that put a lot of gels on the head. That is not easy. So that sounds like a very good solution. And the other option are questionnaire. There are several questionnaires that have like 8 to 15 questions to find the risk of a sleep apnea. And we found a questionnaire that seemed to be the most accurate and well-validated clinically. And said, let's go with these two to the shelters and see what happens. So then that's where I really started to figure out how wrong I was and how much mistake I'm doing in my research. And that's when I shared this questionnaire with 8 questions to two of actually my research partners, one who was living at the shelter at that time, and the other one who is a social worker working at the shelter, and say, I would like to take these to the shelter and know what is the risk of sleep apnea. And it seems quite a simple questionnaire, just 8 questions, yes or no, and then very basic questions. What do you think? And I would like you to take a few seconds, just have a look at these questions and let me know if you feel anything is wrong with this questionnaire from the point of view of a shelter resident. This is the first feedback that I got. It's offensive, it's meaningless, no one will answer, you will get hurt. And I had no idea what they're talking about. So the first thing was, you are asking for a snoring as the example that is your bed partner is going to elbow you for snoring. Which shelter resident has a bed partner? So what does it mean? The other question is being tired. And the example is, do you feel like falling asleep during driving? But you're not driving. How are they going to connect with that? And then in the best case, either they don't answer, or they try to see if they fall asleep, for example, when they are in the bus. But falling asleep in the bus is very different in terms of level of tiredness than falling asleep while driving. So we're actually not getting proper data. The other one is that the gender or sex is usually asked to be men or women. But many people within the shelter, not many, but I mean a good portion of the people within the shelter don't identify as men or women. And not having that is actually adding to the distrust between the shelter residents and the people. So that's the very first point of contact that is going to not only it doesn't help us, but we are adding to the mistrust that exists. And the tools that we're using is actually going to increase the inequity. And that could be so bad that either people may get hurt or they get so violated. The other challenge is how we're going to analyze the data. And then, as I said, there are two ways that we were thinking of recording the sleep data. They're breathing during sleep. And our question is, do they have normal breathing during sleep? Either with this portable device, and the beauty of this portable device is that because it has this module to record brain signals, we would know when the person is asleep or awake. And the other one are these, but this one is like multiple sensors, is harder to set up, and then we may have data dropout. And the other devices are like one that we developed, and it records respiratory sounds to detect sleep apnea, all the watches and wearables. The challenge with many of these devices is that they don't record brain signals, so they don't really know if someone is asleep or not. So by taking these to the shelter, we are making an assumption that everyone is sleeping from 10 p.m. to 6 a.m. or something like that. They sleep overnight. But the reality is this is not the case for many shelter residents. They either have a lot of trauma or fear of their safety, that many of them prefer to actually sleep during the day because they feel safer. So they stay awake the whole night, or they sleep like short periods of 3 hours, being awake for 2 hours, another 3 hours, another sleep, and 2 hours of awake. So if we record data with a device like this that knows when the participant is asleep or not, we may have a lot of missing data because they're connected to this device, walking around at night, sleeping during the day. And that doesn't work. Or if we use these simpler devices and record the data from evening to the morning, yes, we get perfect breathing samples and data because the people are awake and not asleep. So our outcomes are either no good data, or we end up suggesting that they don't have any sleep apnea because in fact our recorded data was during when the subjects were awake. So by not incorporating the end users in the study design from the early on, we may actually get misleading and wrong information. And that's why we changed our research model. And we made sure that we are having a group of end users in our research from the very beginning. We have a group of community expert group who are 4 people with lived experience of homelessness and sleep apnea, as well as shelter staff and shelter managers and care providers to the shelter. And in this case, it's the nurses who are in the shelters through inner city health associates. And we meet with our community experts every other week. We have like 2 hours of meeting with them. And we discuss every detail of the research with them, design and modify the research protocol with them, and then move forward. And we hope that this will reduce our problems that we have. So I'm so thankful to our funding agencies, and more importantly, to our community expert group, that I learned a lot from them throughout this experience. And I don't know how I could have done the research without their help. It's been a very rewarding experience and quite challenging too. It's been a lot of learning for me of how to engage community experts and work with them properly. But I think that that is one of the most important lessons that I learned. Thank you.
Thank you so much. I really, really, really appreciate it. I know that there's lots of clapping and hearts happening in the Zoom, because if we did let everybody unmute at the same time, you would have a roar of applause, but we might never regain control. Well, we don't have control, but regain a little bit of ability to have a conversation. So I'm sure now you can all see why I was so excited to have Azadeh join us, not only for the actual work, but for just the way that you tell the story of that work is what I find really, really exceptional. And I think it's because I work so often with researchers who are kind of, well, frankly, unwilling to say the things that you say. I mean, for me, the two most important sentences that I've heard you say now at two different times was, this really helped me see how wrong I was and how much of a mistake I made in my previous research. And in my mind, that makes you like the most excellent kind of scientist because we have a hope and hell of getting to something that's real and a result that reflects the truth. But so many of people in the world in all kinds of disciplines, not just researchers, journalists, policymakers, program officers, like it's not like about scientists, but so many people are so afraid to say that they have understood something new and that they're going to change the way they're going to do their work. And so I think my question, I'm going to ask a question first, which I usually try not to do, but I'm so excited, is do you feel that has had negative repercussions on your reputation? I know you're a very well-regarded scientist. You're very popular, both kind of scientifically and personally. Has it been a problem for you that you are so willing to say, I was doing this for decades, and then I was shocked to realize that we were missing a key component of the people that should be involved in research design? Have you gotten a lot of blowback, either you or just in general, to be willing to say that?
Not actually. So, I mean, or even if it happened, it didn't happen in my face. So no one was saying anything in that. And it was more of an agreement that this is something that we really need to incorporate in our research. For many people, they may have hesitations to do that or say, does it really matter to my research? Especially, for example, if they think that they're just doing a lot of data science or data analysis, and say, okay, but what does it mean to me to incorporate end users? Which I think it has relevance to everyone. So I received those responses that it doesn't apply to me. And one of the questions now that I ask people is, do you think that incorporating or including end users in your research is relevant to your research? How do you see inequity applies to your research? Is it just for some specific research areas or for everyone? But no, I haven't seen any negative outcomes because of sharing that.
Well, that is good news. And I hope that anyone here who is worried about that can take you as a sign of hope. And what I also really like about your example is that you talk not only about how important it is to include kind of the end users, the caregivers, like the people with this lived experience in the design from an equity perspective, but that it also produced more accurate science, which I think is the bottom line. Like if people are like, that doesn't apply to my field or my particular research project because, we don't have equity goals. I use your example to say it doesn't matter if you have equity goals. If you have accuracy goals, you need to think about this. Okay, so I'm going to stop hogging the questions and let other people ask questions. So again, feel free to either raise your hands, which you can do in the Zoom menu bar. There's a place where you can raise your hand, or if you don't want to raise your hand, you can put your question in the chat, or if you can't figure out how to raise your hand, put in the chat that you want to raise your hand. And we will go on a first come, first serve basis. And okay, go ahead. I am not going to try and pronounce people's names because it'll be disrespectful, frankly. So you can feel free to introduce yourself.
Thanks. My name is Matan. I work for Pine Street Inn in Boston, where we work to end homelessness. And I've worked in some research settings before, social science research settings. And I think so much of what the challenge that we sort of faced was you talked about the importance of incorporating end users and how challenging that was, and you had to have that conversation. How do you balance that with the sort of advocating for the importance of including a certain population like folks experiencing homelessness as end users? Like, it seems like it's difficult, like it's more steps. It's important, but it's more steps, and it's, more to consider. Have you had people say, you know what, it's too hard? It would be nice to be inclusive. It would be nice to have this population, but that's too hard. So why don't we focus on other populations, because we can't do this right? It would be too much work. Have you had that challenge?
So I did have that challenge, that why are you looking at this population? There's so many other populations that you can look at that. And then why to go for all these challenges? I mean, you're not equipped for that, and so on. And for many reasons, I had sort of a personal feeling or agenda that I want to do that, because the reason that this is so hard doesn't make sense that we should stop that. So I'm going to continue in this research, knowing that this is going to be quite challenging. And at the same time, there were so many people that were really appreciating. So everyone that I worked with and get engaged were so passionate about this, and were so willing to spend time on this, knowing how underserved these populations are. And many of them are of like the clinician and my colleague scientists were actually telling me, thank you, that you are sort of leading this project, bringing all of us together to work on that. So many of them were really looking at this as an opportunity to give back to the community and to the research, and not just publishing, the usual research that they're doing. So it was more encouraging. But I had to do a lot of work with my students, because at the end of the day, I have graduate students. I have a staff that have to do a lot of help and work on the project. And there was a lot of things to prepare my research team of how to work on this project, how to get engaged, how to make sure that the safety of my research staff is also protected. And then also they are prepared in terms of the language that they're using. They're not adding to the stigma and so on. So definitely there has been a lot of training for us.
Thank you so much. There are a couple of questions in the chat and also some great resources. Again, I should emphasize, feel free to share resources and links in the chat as well. I should have said that in addition to the question. Let's go to this next question. Can you tell us where you are in this research process? Are you still developing the design, or have you actually started to collect data?
So we started to collect the data. It has been very slow because of all the breakouts in the shelters, and also because we had to start everything virtually. But we had other challenges which are very unfortunate, like one of our community experts who lives in the shelter passed away because of the poor access to care. And she was one of the best example of how much problem the system has. I mean, she's one that was very passionate about taking care of herself, about research, a very good writer. She had disability, and she was key to really help recruit participants from the shelter. And then they had a sort of wellness checkout at 9 a.m. and she was fine. And when they did another checkout at 11, they found her that she passed away in her bedroom. Again, just because there was no checking on their health, even though she had several serious lung and heart disease. So we had a lot of similar challenges like that. And then, but we started data collection. The people that we recorded data from have very high degree of severity of sleep apnea, which is undiagnosed and untreated. And then we're continuing the work on how we can use the data or the the experience and the knowledge and work with the shelter residents to develop better technologies that they are willing to use, but we can also record or monitor their health in the shelter without even the need of a complex system like a portable polysomnography device.
Okay, that is very, very, very helpful. And of course, COVID is still quite active here in Toronto. So it is a whole layer of complexity on top of, several hundred layers of complexity. So again, thank you so much for even, being courageous enough to do this and committed enough. Second part of that question I'm gonna amplify is I like the point about accuracy. How, when you changed what you were doing, not only was it more equitable, it was more accurate. I wonder if you have any information about how much of the information was unusual before with the old approach. I keep getting the question of whether it's possible to quantify the impact of doing data work more equitably, but there is a paucity, I don't know if that's the right pronunciation, of data to address that question. It means a small amount, I think.
Sure. So this is another experience that I had with including the end users in the research design. And that's for another study. So after the experience that I had with people in the shelter, I said, okay, this was very helpful for me. And now I want to actually apply that to all my other research projects. I want to make sure that every research that we're doing, we have a group of experts with lived experience of that disorder to make sure that and then share our research with them. And we did that for another study that was about asthma and sleep apnea. And what happened was that, so we had in the first meeting, and a lot of the research I'm doing is going to be writing a grant proposal. What is the big question of the grant proposal? And in the first meeting, I just asked the people to tell me about their experience. This was like another 3-person with asthma and sleep apnea. And they told me so many things about like what they do on an every night to try to improve their shortness of breath during sleep, like that, how they're trying to sleep sort of with the multiple pillows, or the challenges that they have with the sleep apnea treatment devices. That I did not know that. I mean, one of them was one that I thought that I'm very smart, that I ended up telling that the solution and outcome of our research could be suggesting the people to sleep with multiple pillows. If I had talked with them in advance, I could have got that much faster than not waiting like 3 years or 4 years to come up with that solution, because that's something that the people are doing based on their experience. Or the challenges that they brought up, for example, of using the CPAP devices with the mask that is commonly used for treating sleep apnea, are the challenges that we usually don't hear, that people may feel claustrophobic with the mask, and that's a big challenge that people stop using CPAP treatment. Or how the challenges are very different in the older population compared to the younger population, and how those are really going to affect the course of the study, the course of the treatment, and how we have to make sure that the people at the end will be using our treatment. So actually doing that and getting those firsthand feedback from the people was very helpful to the design of my research studies, not just for the homelessness, but in my other studies. So I think it's really worth it. And now I'm trying to practice that in all my research projects.
That is amazing.
That's another example of how wrong I was.
Yeah, or what an amazing scientist you are, really, and what an amazing human you are. And that is a really, really helpful comment, and I think it leads to many, many, many more questions. I will definitely have to have you back. But one of the follow-up questions that a few different people are asking in a couple of different ways, some in the chat and some are private messaging me, is kind of, when you include the community advisory groups, and when when you start to pay attention to like the people that are involved in research, that immediately opens up a whole different kind of part of the relationship, which I think personally is one of the reasons that sometimes researchers are hesitant to do it, because one of the questions that's coming up is kind of how do you balance the expectation the potential expectation from study participants that they can receive care if you identify an undiagnosed sleep apnea condition? Are you able to connect the people that you diagnose with care? And if not, how do you manage expectations with participants? Really similar questions to this are, very bluntly put, how do we take care of people in research? Another person is saying, what happens if people are involved in helping you design a grant that then doesn't get funded? So that's similarly like, how do you manage expectations when you're bringing people into the research process that aren't formally trained academic researchers and have a really different set of needs? Like they're not accruing value in the way that an academic might be.
These are
Huge question,
excellent questions. These are excellent questions. And I'm going to answer them in probably 3 different ways, or like breaking them in 3 different things. So the question that Alexandra asked about the treatment, that's a very important question. And that will come to another topic about sustainability of the research. And I just come to that briefly, that specific one. Before getting into that, it is a quite challenging experience, especially if you're dealing with working with the underserved population. In my own experience, like for example, I had this that someone called me that I need help because I'm going to be out of my shelter now. And I'm like, okay, let me see it was like 8 at night. I was trying to put my daughter at sleep, a 4-year-old that doesn't sleep without me. So I was in bed with her, trying to put her to sleep. And then I'm like, okay, I will try to take care of this tomorrow. And the person on the other side said, no, I need answer now because I'm in the street in a few minutes. What are you going to do? And I was not prepared for that. I mean, I'm not a social worker. I didn't get training for that. I didn't even know how to do it. I just knew another shelter manager. Just the fact that now I have to also take care of this and I can't just let that go and then forget about everything, try to find the accommodation for this person that I care for, was one of those examples of you get involved in other aspects of the research, of interaction with the people that are not part of your research and you don't know what to do. And there were more examples of this. So yes, it was it was a learning. And then for me to find the balance that where I can help and do my best to help, and even tell them that, okay, these are the things that I can do and these are the things that I cannot do, was a process of learning that happened. It also happened in terms of my research staff. When you say, how do you take care of people in research? It is very important that there were some times that the community partners had unexpected sort of requirements or expectations from my research staff that are not trained for that. Because again, sometimes these lines are not very clear, that who is a social worker, who is a support staff, who is a PhD student, and trying to manage that and say, okay, for these ones or these sort of helps, come back to me and not to the research trainee. So really balancing that was part of the project, and it happens. It's not that it doesn't happen, and it was challenging to do that. The other part, and then also even to know the limitations of my research team, because they are not trained to, we are not learning how to work with the community expert or the expectation of the people. And then we just started having these meetings within the group that, for example, if you have a meeting with a community expert, don't try group, especially those who are older or just from the general population, don't make expectation that everything is going every 5 minutes and so on. Make sure that, for example, you have a time for the people to know how to get familiar with Zoom. It's not a common thing. We all do use Zoom, but doesn't mean that everyone does. So really Making sure that my research team knows what their expectations should be was an important part of that training to the new people or the new group within the team. In terms of the question about the balance of the treatment, that's actually one of the very first thing that I learned. And that was when I was working with the expert at the Inner City Health Associate that were giving care to the shelter residents. And the first question was, what happens if you find that someone has a sleep apnea? Then what happens? Or they have other sleep problems like insomnia, having difficulty falling asleep, which is not part of our research program. And how you make sure that they're not get lost or like just left alone. So really that part of sustainability of the research and giving back to the community is a very important part of that. Unfortunately, it's quite common for researchers to go to a community, do their research, get the data and come back and leave the community left of, okay, now what? What shall I do? So one case was go to the shelter, say that, okay, you people have a sleep apnea. I got my data, bye, thank you, I got my publication. And now that is going to add to the mistrust and problems of the shelter, both the residents and the staff, because I'm giving them the problem. I'm telling them that you have a sleep apnea without any solution. And now it's like adding to their misery. While the solution should say, okay, if you have a sleep apnea, then this part of my research is designed to provide treatment for you. And our project is actually we provide treatment and then we follow up for a period of time. And after that, we give the treatment to them for free. So they can keep their treatment, after the end of our research protocol. We also make sure that they're connected to a sleep physician. So if they have other sleep problems, they can get care, like for example, for insomnia or for very fragmented sleep. Or if they have like heart disease that gets worse with the sleep apnea, they can be referred to a cardiologist. So really making sure that we make the connections in the study design that even when our study part is done, they will get the other care that they need was an important part of the study from the beginning. There were so many other things that were raised, like how about their housing, the mold in the house that they have, or the problems with the shelter staff that they may just get them out of the shelter because they don't have. And we don't have solutions for that. This is far beyond our expertise. I said, okay, these are the things that I cannot do anything with. So it was a learning of what I can do within my capacity to make sure that the research is sustainable in a way that it gives back to the community, and what are the areas to acknowledge we cannot do help.
Fantastic answer to a giant question. And again, just so much transparency about the challenges and the realities of doing equitable research. It involves having to think and plan for really different questions than you were probably taught in your kind of formal academic graduate school training to be a biomedical engineer. And you have such a fantastic, brilliant way of expressing it. I really appreciate it. We have way more questions coming in through the chat and direct messages than we will ever get to. So I'm going to try and pick out some of the ones that are getting asked a lot. And one of the most commonly asked questions that I don't think we've touched on yet is, and it's something that a lot of people are asking, is when you form a community panel, how do you choose people to be on the panel? And as kind of a partner question to that is, are you concerned about there's going to be inequity about who gets to be on your panel and who doesn't? And then the last part of it is was there a conversation about compensation of your community panel? And if so, how did that go?
Those are excellent questions. In the two studies that I did, in one of them, I reached out for the homelessness, I reached out to the other scientists, and they had a working group of the people with the lived experience that they were providing advice, and then we asked who is interested to join us. And our criteria was having a sleep apnea and then experience of homelessness. So these two were like what we wanted. And then based on the need that, for example, I realized that I have to make sure that our group has representing the racial distribution of people in the shelters, and make sure that, okay, if we don't have some of the racial background, we will go and actively look for the people within that racial identity. So one of my criteria was to make sure that our community group represent the population that we're going to, that is of our concern. Doesn't mean that it is necessarily equitable. That is one of the things that one of our partners raised out, that if you want to recruit community partners, we should send it like an advertisement to everyone and ask the people, like for example, in the shelter, if they're interested to reach out to us. And that's the other thing that we're going to do. In terms of another study that was on asthma and sleep apnea, we started with the people who were in our study, participated in the past, because we wanted them to have a good understanding of our research and the challenges. So that experience of being part of the research as a participant was important for us. Doesn't mean that it is equitable, and that is something that we are working on, how to have a better approach. And also, one of the activities that we're doing through the University Health Network is how to have like a database of people who are interested to be community expert patient partners, and make sure that that list of the people, or that larger group of people, is representative of the community, not just those who are commonly coming to the hospital. In terms of the compensation, it was a very clear sort of setting. So we are paying our community partners on a $30 per hour. So that's sort of a contract, a consultation. We have a very short sort of a contract of one page, that what are the expectation, the number of hours per month, and that is more of a range, like from like minimum of this many and maximum of that many hours. And then they are telling us how many hours they are in the meetings, but then they also spend time outside of the meeting reading material, reviewing our application, or making community contact, and they just give us that number. But it is a paid position.
And was it challenging to make that a paid position? Did you have to rearrange funding or get permission from various funders?
No, it wasn't that much of challenging to do that. A challenge is more from like the system of the hospitals. Many of the community partners would like to get cash, not like gift card or so on. And the hospitals don't have any system to pay cash. So that's really how to find a better way to pay them the way that the community partners want is the bigger challenge. Securing funding for that from the granting agency wasn't a challenge.
Right. That's a very, very good point. the practicalities of it, getting it in theory, it was not a problem, but then getting it in a practical way that is useful to, somebody who doesn't want to receive a wire transfer
Exactly.
is a really, really good point. And I again really, really loved your explanation about how you went about finding the expert community patient partners for these two projects, and the fact that you're aware that it's probably not perfect, and frankly, probably never will be, and that's not a reason not to try. As long as researchers or scientists, we can document this is what we did and this is how we did it. We can provide the transparency that can like put the research in context, rather than being afraid to try something until we can, make it perfect, which of course.
You're absolutely right. Given that we have a limited number of people that we can have, we know that it won't be perfect. But at the same time, we are learning a lot, and we know the challenges that we have, or at least some of them. that I think it's an experience that everyone should try.
Well, I think we'll leave it on that note, because I think that is the best message ever. This is something everyone should try. And I have to apologize. I know there are literally dozens of more questions that haven't been answered in the chat. We will ask Azadeh if she will return again and give us an update as she continues this amazing work. And to kind of answer two housekeeping questions, are you going to be able to rewatch this? Because some of these answers are so valuable. And the answer to that is yes. We always post the recordings of this into our community forum, which is just community.weallcount.com. That's a free thing. It doesn't harvest your data. It doesn't serve you ads. It doesn't sell you stuff. It's just a forum that's on our private server. So you can look at all the videos there, and you can also continue to ask questions there. I know people are putting really valuable resources into the website about other people in other areas that are also developing ways to work with specifically communities experiencing homelessness, and also specifically ways to get patient voices into research. And those are really valuable. So feel free to hop over to the forum to have that conversation anytime you want. We really encourage that. And secondly, a couple of people have asked about these posters behind me. I'm always a little bit embarrassed, but really proud of these posters. I put a link into the chat at Society 6. These posters were made as a Christmas present at first for me by someone. And then that person has decided to make a new batch of posters for me and the community as a Christmas present every year. So we have now 2 years of posters, and they're kind of, data equity posters, and we do sell them, but we do not retain any profit. All of the revenue and income from selling these posters gets donated on a monthly basis to mutual aid societies and communities of care. You can see on the link which one it is for each month. So if you want a poster or a t-shirt or notebook, feel free. I do really like those posters. And so thank you for asking. And most importantly, thank you so much, Dr. Yadollahi, for taking the time out of your incredibly busy schedule. You've got a young child, you've got a dog, you've got an amazing career, and you took an hour to help us understand how to do our work better by sharing transparently and brilliantly how you're doing your work. And I cannot express how grateful I am for that, and how valuable this hour has been, and how soon I will be circling back to see when you can come back. But
my pleasure.
Great. Thank you for coming, and thank you for everyone else who came and asked your questions and shared your resources. And we will be back here next week at noon Toronto time. And have a great rest of your day.
And I'm
Bye.
so thankful. It's been an outstanding experience for me both times, and the questions were wonderful. Thank you.
Thank you so much. Talk to you soon.